So, hello, lab experts. Once again, welcome to the RoK Diagnostics Podcast. In today's episode, we are going to be going into a more general direction. We're going to be talking about urinalysis. And to help us in this discussion, we are here today with a medical laboratory scientist, Arinze Stephen, and he's going to tell us a little bit about himself before we begin. So could you tell us a little bit about yourself and what got you interested in the field of medical laboratory science?
My name is Stephen Arinze, medical laboratory scientist. I graduated from University of Nigeria in Nsukka, where I read medical laboratory sciences in 2012. I did the internship at the State House Medical Center, RoK, Abuja. After that, I also did my services, like National Youth Service Corps in Abuja. My PPA was at Gariki Hospital, Abuja. After service, I started working with His Glory Hospital, Koka, Lagos. So that is where I presently work. Yeah. Thank you.
Thank you. And what got you interested in medical laboratory science? We all have our different paths to which we some people actually looked for the field and then came gently into it, and then some of us kind of fell into it. Which one are you? What group are you?
When I wanted to go to the university, my first choice actually was medicine. My second choice was medical lab science.
Okay.
That medicine thing was, we didn't know much about medical lab science actually. What we knew was medicine. We thought anybody in the medical profession read medicine. Maybe after reading medicine, they will now go out to specialize, maybe as medical lab scientist, physiotherapist, radiographer, and the rest like that. I never knew it's possible to, study something related to laboratory first. Because I also hear of pathologists and the rest. So that medical lab science I just put was because I saw it there. I didn't even actually believe, it was actually there. It was medicine. That was my intention. But, all the same, as God will have it, I got medical laboratory sciences, and I'm happy I read the course. Because if I had read medicine, I would still find myself in the laboratory. Maybe as a pathologist also. But I'm fulfilled as a medical laboratory scientist. Yes, so much fun to be a medical laboratory scientist. You play with bacteria, play with parasites, you see them, you look on these things, you diagnose, it's fun to work in the laboratory.
Yeah.
So yes, that's just some doctors fight us and they want to work in the lab. So it's not, it's actually fun. I would just imagine what will it be if I become a doctor, sit down, consult people, maybe I'm a surgeon or something, then go to the theater, come back, consult, No, I don't like that kind of, I think I like the way I'm, working with the microscope, working with machines, and diagnosing diseases, and, seeing the things that are rare to come by. I'm happy.
Yeah. So essentially, you fell into medical laboratory science, but then you loved it from that point onward.
Yes, I loved it so much.
So talking about diagnosis and then using all the tools that we have in order to diagnose patients, today we want to talk a bit about urinalysis. Now, urinalysis, I think, is one of those tests that people outside the hospital don't really know about as much until, let's say, a doctor asks them to urinate in a cup or in a sterile container. And then usually, I guess they don't even know what happens to that urine sample or where it goes. So for someone like from the general public who is watching this, who may like to have an idea, what is urinalysis?
Okay. Urinalysis is one of the compulsory tests, everybody should do. Even if you're not you're not in the hospital bed, maybe you just visited the hospital, urinalysis is advisable. It's advised that you do a urinalysis test because it doesn't take time. In fact, in less than 5-10 minutes, you should get your results. Urinalysis is compulsory in the sense that it give a doctor a summary of what is actually happening in your system, like the kidney, your liver, and then the blood system to check if someone is diabetic, if there's any serious issue. Urinalysis has actually saved a lot of people. It has saved lives. It also means routine urine analysis. So they just combine the two words to start calling it urinalysis. So routine urine analysis. So it's a physical, chemical, and microscopic examination of urine. Although some labs don't do microscopy, but what some lab understand it as is just the physical and chemical examination of urine.
Yeah. Now, what does the microscopy allow you to do, to determine?
Okay, you use the microscope now to view the urine sediments. After studying the urine, you decant, and then you view the sediments. Then you see dead white blood cells. If they are high, infection, which can be, which is dangerous. Maybe probably person having a urinary tract infection, and then or pyelonephritis. Okay, so the point cells, the epithelial cells, and then for a woman, when you look at pus cells, when you look at the epithelial cells, you might also be seeing some clue cells. There are some cells called clue cells, C-L-U-E, clue cells. These are cells that, they are actually epithelial cells, but they have bacteria in them, and they can serve as pointers to, what is it called? Bacteria vaginosis. And then the other things you also look at for crystals, casts, bacteria, yeast cells, red cells, red blood cells, what else, and etc. These are the things you look at for them in the microscopy. They're also actually important, like for kidney stones. If you see more of crystals, although the size actually is important too. That one will be done from scan to know the size of the crystals. You start talking about kidney stones. And then even you to looking at the size from the microscope, you can tell, is this kidney stone or not? The size matter a lot, especially on a fresh urine sample, maybe urine sample that is not more than 6 hours, after production. Because the longer the urine stays, the more the crystals will start coming,
developing. So from what you're saying, it looks like you can do a lot from the urine, because originally you talked about being able to assess the state of the kidneys. You talked about being able to assess the state of the liver. You talked about inflammation. So it looks like in the urine, there's actually a lot of information to be able to assess anybody's health. So I guess that's why you were saying that it's one of the compulsory examinations that we should do.
Yes. There are so many things. In fact, when I start going through this urinalysis, you find out that there are so many things one can do with a urine sample. And this urinalysis, which is a deep stick test. When a deep stick, now you get the strip, you dip, and then you read. It's a 2-minute test, but it's powerful.
Yes,
it's powerful. It can show you a lot of things. Now let's talk about, before we continue, let's talk about collection of urine. That is also an important thing to talk about. Now, the urine sample, the best urine sample to be collected for this urinalysis is a clean catch urine or midstream or a catheterized urine samples. I will explain. Clean catch. Now one wants to get the urine. One is advised, when the person wants to urinate, the person shouldn't just put the bottle immediately and start collecting the urine. No, the person should just wait. As the urine is passing through, the person is urinating, then in between, that is the urination, the person will just put the bottle. Then before the person will even stop urinating, the person will remove the bottle immediately. That's what I mean by a clean catch urine or a midstream urine, in the sense that the person wants to urinate, you pour the first portion of your urine, you stop, you pause. Then you pour the second portion in the bottle, then you pause again. Then the last portion, you pour out.
Yeah.
Yes, you pour the last portion. Then for a catheterized urine, a urine you get from a catheter. A catheter now, yes, the bag that enables those people that have kidney issues or some other issues to be able to urinate. You pass a bag, to their bladder to collect the urine sample. So you can also get the urine from the catheter. So
now,
these are
when it comes
the three.
When it comes to these methods of collection, why are there different methods? How come there is not just one method?
When you look at them very well, they are actually, especially the clean catch and the midstream urine, they are almost the same thing. But you need to explain to people what you actually mean. You are looking at for the middle portion of the urine. Why is this so? One is because the middle portion of the urine is seen as the part of the urine that is free from skin flora. Yes, okay. Like vaginal washings, secretions, all those things will be around the private parts. For a man, so all those things, even semen, maybe the person just finished having sex, and you want to get urine samples. Yes, there's some traces of the semen will be in the urine. So all these things, you tell them to, that midstream urine or a clean catch urine is very important for the test. And then the skin flora. Sometimes you might even see, maybe if the urine should be cultured, you might be seeing something like Staphylococcus epidermidis. And then someone will say, oh, this is infection, is infection, is this one, is that, So avoid all those things, contaminant from the skin. Clean catch urine or a midstream urine is the best. And then for a lady too that is menstruating, midstream urine still, although there might still be traces of blood in the urinalysis, but midstream urine still is the best.
Let's say I'm a patient and then I come to the lab. Do I have to take the sample at the lab right then and there, or do I have to go home? I think there are also some samples where in some cases they may ask you to take it at a particular time.
Okay. That's a very good question. The best urine sample for urinalysis usually early morning urine. That is the best urine sample for urinalysis. But in the situation whereby someone was rushing to the emergency, probably the person is having diabetic ketoacidosis and the patient is in coma. Okay? But when I start talking, you understand what I mean by diabetic ketoacidosis. And patient, there is the high point of diabetes, mellitus. And the person is in coma. You will not say, oh, and then, or the person is about to go to coma. For example, the person is feeling dizzy. You will not say, wait the following morning before you get your urine sample. Or the person is having some pains, abdominal pains, and the doctor is suspecting pyelonephritis, and he wants to know if there is a leak. If you don't do a urinalysis, let's know if you can see leukocytes. Because when you see leukocytes, it means the person has a urinary tract infection. The person actually has infection. And the doctor wants to just have an idea to know whether to recommend antibiotics. And then you go ahead with the urinalysis, the culture, and then urinalysis, but the doctor wants to know. You will not be telling the person, come back the following day. You don't know whether the person, by come back the following day, whether it become worse. Whether a kidney issue would have come up, that kind of thing. So the best urine sample is actually early morning urine or morning urine. maybe a few hours after waking up, morning urine. But in a situation whereby you can't get more early morning urine, the patient is advised to give up spot urine, because if the case is serious. But someone like you now, that you're looking healthy, you're going to the hospital, I think the best urine samples for you will be that
Early morning
urine, because there's nothing actually obviously wrong with you. You just want to do a checkup. So that early morning urine is best for you. Okay, so I was talking about collection of the urine sample. I talked about how you collect the urine samples, and this should be done in a clean, dry container. Okay. Clean, dry, sterile container. Container that has not been used before. Give to the patient to get the urine. But some people, they reuse bottles. Yes, for me, it's not advisable anyway, but if the patient can pay a lot for urinalysis, why not give them clean bottle? How much is the bottle?
Bottles. Yeah.
Yes, clean them, give them sterile bottle to get their urine. And then you examine the urine as soon as possible. Yes, even everything you wanted to do, including the microscopy, culture and sensitivity, including the microscopy. I'm not talking about, after culturing now, you start doing, microscopy and the rest. But everything should be done as soon as possible, ASAP. So routine tests for urine analysis. Certain tests are graded according to their degree of accuracy. Screening or qualitative tests result as positive or negative. So when you talk about qualitative tests or screening tests, you put them as positive or negative, or some people use present, absent, depending. And then for semi-quantitative tests, results are graded as negative, trace, 1+, 2+, 3+, or 4+. Urinalysis does not account accurately for quantitative test results. It doesn't account accurately for quantitative tests. When we talk about quantitative tests, I'm talking about figures. You start using figures now. Let's say, for example, you did urinalysis now, and the glucose is showing 2+, and then you start you start to quantitate. Oh, this should be like 200 milligrams of glucose per daily. This is 200 milligrams of glucose. I think you start saying that kind of that urinalysis will not give you the accurate value. So for you to get the accurate value, you start talking about using machines to do some tests, like glucose tests, or depending on the parameter you're looking at for, to quantitate it accurately. So it will just give you results for qualitative tests and semi-quantitative tests as well. So the physical properties of physical examination or microscopic examination of the urine, that's what I want to talk about now, because the physical examination, microscopic examination, they are based on the physical properties of the urine, as we're going to see now what I mean by the physical properties. Properties such as the volume, color, appearance, odor, foam, specific gravity. You might know when I talk about specific gravity, when I explain that, you understand. And pH will be talked about. So these are the physical properties you look at before you start talking about the chemical properties. Now, for the volume, number one, volume of urine, okay, is actually proportional to water intake of a person. The more someone's taking water, the more someone should produce more urine. Okay, that's not an issue. But when it becomes an issue is when someone starts eliminating more than 2 liters of water in 24 hours, more than 2 liters. Like I don't know which country are you calling from. There's some country use here, the beverages here. Yeah?
I mean Benin.
Benin Republic.
Yeah.
Benin Republic. Okay. Okay. Oh, and you speak English this way. Okay.
I started learning a long time ago.
So Okay. Now, if you get like a Coke bottle now,
Yeah.
250 cl Coke bottle. In Coke bottle, 250 cl Coke bottle makes 1 liter. So if someone starts urinating to more than that, for the Coke bottles, that is more than 2 liters. So it calls for serious medical attention. That is, they call it polyuria, especially when just even if you take too much water and you are urinating that way, and you start producing more than 2 liters, 4 bottles of Coca-Cola, 50 cl Coca-Cola. That is more than 2 liters. It is called polyuria, and it calls for concern. So the person should be advised to do a urinalysis test, because diabetes mellitus can cause that. Type 2 diabetes, chronic renal failure can also cause that. And then in the case where they are absent, polydipsia, there is a situation whereby someone takes too much water. The person, I don't know, but person on what cannot be explained, start taking enough water, even when the person is even filled up. Person continues to take the water, continue. I don't know. Some people, I don't just know, but you might have situations like that. Maybe you tell somebody, take enough water so you don't have kidney stones, and then the person is afraid. Oh, I don't want to have kidney stones. Then the person starts consuming a lot of water. You understand? So that can also cause polyuria. So in the situation whereby all these things are absent, confirm maybe the person is also taking too much water. And then there's another thing again that most hospitals don't check for. It is also called diabetes, but they call that diabetes insipidus. Okay, insipidus is a non-glucose diabetes. That is not connected to glucose, but they also have similar symptoms with diabetes mellitus, but not with the glucose. The glucose will be negative, but the person will be urinating frequently, uncontrollably, all those similar things. And then those 3 P's of early symptoms of diabetes mellitus: the polyuria, polydipsia, polyphagia, too much excessive eating, like phagia, polyphagia, polydipsia, too much water intake, polyuria, excess urine. So some of those things too will be related to that person. The person will be having those symptoms, and the doctor might be thinking, oh, this person is actually having probably DM, and but the doctor is not looking at DI, diabetes insipidus, which is also another diabetes, but people mostly don't talk about that. And then the doctor might examine the person and say, oh, you are just fine, you are just okay, stop consuming too much water. The person goes home and then the person dies, or the person comes up with some other issues. Oh, then so the doctor, I said doctor. So look at the volume of, when you talk about volume, you talk about polyurias. These are some things doctors will look at. Maybe from patients complain, oh, I've been urinating frequently, I've been taking too much water, I used to have increased taste, this one, that one, Okay, I just say, let's do urinalysis first. Let's know what I'm thinking, and then recommend a urinalysis test. And then we also have another condition called oligouria. Oligo means few. Then urea means urine. So few production of urine, like production of 0.2 liters of urine in 24 hours.
Yeah.
Less than 0.2. When I say less than 0.2, it's like saying 20 cl. Okay, like half of the Coca-Cola bottle, or more than less than half of the Coca-Cola bottle, 50 cl bottle. And someone is producing, in 24 hours, all the urine is just like the half of the Coca-Cola bottle. So there's also another condition. Causes could be maybe probably the person had been dehydrated, maybe the person had been vomiting, maybe stooling, watery stool, that is diarrhea. Okay, that is when someone is vomiting and person is stooling, watery stool, the person can also have dehydration. That is the person no much water content,
Yeah.
and the water content will be reduced. That's what I mean. So in that situation, the person will start having oliguria. That is, the person will start producing small volume of urine, but the body is trying to conserve water. And then you also look at what if there is obstruction to urine flow, or the person is having acute glomerulonephritis. That's another kidney issue. Okay, and then these are things you look at for. These are usually from complaints before the doctor recommend a urinalysis test. And then anuria. Anuria means means not at all. That is nothing, no urine. Anuria, so a lack of urine. So there's a situation whereby there's a complete absence of urine formation. So the same causes of what I just mentioned, the things that can cause for oliguria, can also cause for anuria. So the patient can, I can't even produce urine again. I don't know. Probably there's a kidney issue. The kidney can no longer filter urine. Can't actually do all this function. Filtration can no longer do that. So probably the patient might need external help. Maybe passing of catheter and the rest or something else. So now the next physical property is color. Now, this one now, the patient here now is no longer in the doctor's office now, okay? Because some of the volume is actually from patient complaints. Even if the patient produces urine and you are to work on spot urine, you can actually tell whether the person is maybe due to oliguria or due to polyuria from the urine volume, because probably the person has urinated often that day before even getting that urine sample. So the patient is bound to get you low volume urine. So you can't be saying this is oliguria, this is because of polyuria, or diuresis, due to excessive water intake. So the person has come to the lab with the urine sample. So the first thing they look at is, normal urine should be straw. Straw, what I mean by straw is something that is like a faded yellow. Okay, faded yellow, straw, yellow, or amber. So normal urine samples should be straw, yellow, or amber. Amber, slightly, looking darker, kind of. Or yellow, looks yellow, normally, but straw, lighter in color. So you look at the color, and then the color of urine is, there are three things that give urine this color, whether the straw color, or everything depends on the quantity, or the yellow color or the amber color. There are three things. One is uroerythrin. Secondly, urochrome, a yellow pigment. Then uroerythrin is a byproduct of red cell degradation, when red blood cells are degraded. And then there are other colors you look at for pale urine or a colorless urine. Urine can also be colorless. One can produce urine and urine will be looking clear. Colorless, like water. You might even mistake it. You say, is this water the person poured for us or what? Colorless, pale. And most diabetic patient urine also come that way too. Some of them look like that. Apart from just being straw, some of them can also look that way. And then urine too can also look clear red. Like which drink now is clear red? I don't know. What I mean by clear red? You just look at it. This is just red, or just let me see clear red, you call it, because the urine is just looking clear red. That is, when you see that kind of urine, is actually hemoglobinuria. That is your hemoglobin, the pigment that makes the red cell red. That makes the red cell red. Without this pigment now, hemoglobin, what you have in the red cell is, we start calling them ghost cells. The red cell they become ghost cells. So calling them ghost cells. But with this hemoglobin, that's when you start calling them red cell, because they make red cells to be red, and because they help in carrying oxygen. That is the main function. So they to help to transport the oxygen in your red cells. So, and then probably the clear red urine may be as a result of incompatible blood transfusion reaction. In case we do this, if the doctors come and say, the patient is writing the blood, you people cross-match for us, that the patient is receiving, the first thing to do, look, I will have a urine sample of that patient. Yes, if you get the urine sample, you will see hemoglobinuria. That is, at the lysis they're talking about, because the urine should be red in color. Then there's another situation of color of urine you look at. These are abnormal urine I'm telling you about. I've told you about, mentioned already the normal urine color we have, but these ones now are the abnormal ones. Then we have black or dark brown urine. Okay, black or dark brown urine. There are other causes too. Somebody is having tumor or melanoma, tumor of the melanin gland, or person can give you black or dark. So there are some diseases, like phenylketonuria or acanthonuria. There are other things, Time will not permit us to start talking about all of them. They also have milky white urine. Some urine, you look at them, you've seen something that looks like milk inside, or sediment, white, how will I put it? They look like as if somebody put something like white powder inside the urine.
Yeah.
I say the white powder is not dissolving. If you mix it together, they will mix with the urine and they look like milk. In that situation, you see that more of that in the situation of microfilariasis. What I mean by microfilariasis, there are some worms, like it's common now, it's endemic in Nigeria, and people don't know much about that. Yes, I see that a lot in the hospital where I work. Some urine you see some worms. We call them microfilaria. Although there are some that are normal flora, there are some that are common in Nigeria, like your Wuchereria bancrofti and then your Lua. These two, they are common in West Africa, common in Nigeria, and everywhere. Some patient can come with some diseases, with itching, rashes, injury all over their private parts, and sometimes the injury might even be making syphilis, primary chancre of syphilis. There's this injury on their penis, You might do syphilis test and it might be negative. The best thing to do is check out for that microfilariasis. You might be lucky to see it, And then you see sometimes people have come up with rashes, red rashes, and then itching, all over. They're itching, even in the private parts, so that they might think it's the water they've been using. They might change water. It will still continue. Use cream, all sorts of things. Drink all sorts of antibiotics. Use all sorts of things, and then the situation continues. The problem continues. It's degenerating. You see, I've examined. I can't count the number now. It's just rampant where I work. People there. So, are you still here?
Yes, I'm here.
So it's just rampant. You see them with that kind of disease. So you should know this is a case of microfilariasis. So because not all urine appear that way anyway, not all urine. They call that chyuria, but not all urine can come up that way. Sometimes even your non-straw yellow amber colored urine can also carry some of this microfilaria in them. You can also look turbid as well. Yeah. So the next one is appearance or transparency. So the scientists used to look out for the appearance or transparency, whether the urine is clear. A normal urine should be clear or slightly turbid. Even the turbid urine too can also be taken as normal urine, depending on the procedure the person took in producing the urine. And then if the person actually took enough water, or the person depending. But a cloudy urine is not actually regarded as a normal urine, because in some situations, when I say cloudy, it looks like cloud. The urine starts looking like cloud. The light won't be able to pass through. When you look at the urine, you'll be able to see light passing through it. But for a turbid urine, light will be able to pass through, but you'll be seeing particles, solutes, solutes in the urine. That's what I mean by turbid urine. Turbidity, high turbidity, and all the rest. So, but an ideal normal urine should be clear. So in some situation whereby, because after some time now, if you check the urine, you see that the urine is slightly turbid. Because if you didn't check immediately, because urine left for some time, maybe some hours, like 2 or 3 or 4, So slightly, turbid urine too can also be said to be normal. And then We'll come back to some of these things later. I'm just trying to tell you some of these properties. Then odor. Now, as a good scientist, odor can tell you if this urine actually has urinary tract infection, even without dipping your stick or not. Now, a faintly aromatic urine, a urine that has small faint aroma, faintly aromatic, sweet-smelling urine, is actually a normal urine. That's how you know normal urine. But there are some urine, that have this fishy odor smell. That means this person has infection and is looking cloudy or turbid. This person has infection. Urine like that, they are hardly clear. You can't say most urine like that, they are hardly clear. Those kind of smelly urine, they're hardly clear. And then there are some cases whereby the urine might have the fruit smell, might not become intense. It might become too intense. That is probably if the patient is diabetic now, or the patient has been starving, I'm not eating for some time. Maybe the person is fasting, maybe dry fasting, 3 days or so. Such urine should have that kind of smell, intense fruity smell or aromatic smell. That is due to ketone bodies. If you run dipstick test for the patient, you find out that the patient has some of these ketone bodies are present there. So as I go on, you will understand what I mean. Now, the next thing I want to talk about is specific gravity. My time is fast spent. Specific gravity, the weight of urine over the weight of equal volume of distilled water. That's specific gravity, also known as relative density. So what this tool actually checks for is, it measures the amount of dissolved substances in specific gravity. If your urine is turbid now, the specific gravity should be higher than a urine that is clear. So if the solute particles in urine is high, specific gravity should be higher. Okay, so it tells you about some doctors use it to detect for DI, diabetes insipidus. Because for diabetes insipidus, specific gravity is usually low, very low. Like the one you have 1.005 or 1.00, depending on your dipstick, urine dipstick. So it can also be like that, maybe without 1.000 or 1.005. Some doctors use it to check for diabetes insipidus, because this is an area of diabetes that is usually neglected in the hospitals. They look for DM, diabetes mellitus, the one that is common. So this is for the specific gravity. And then pH, freshly voided urine usually has a pH range of 5.0 to 6.8. On standing for a long time, urea, if it contains urea, or most urine contains urea anyway, urea is converted to ammonia and carbon monoxide, making the urine alkaline. Therefore, alkaline pH might indicate an old urine specimen. Okay, alkaline pH indicates that the urine is old. This is an old urine specimen. Although my battery is low anyway, I'm having 3%, so I don't know, but let me continue. Let me see how I can finish up by 5:35. So alkaline pH might indicate an old urine specimen, unless it is known to be fresh. So when you see a pH of urine, 7.5, 8.0, or even 9.0, depending on your stick, just know that if urine is fresh, this is a serious bacterial infection, because the urea is being converted to ammonia, and ammonia now makes the urine alkaline. So these are things to look out for. So then, chemical examination of urine. For the chemical examination, we look out for the proteins. Normal urine contains only traces of proteins, or not at all. Normal urine contains traces of proteins. So when I continue, you understand what I mean by proteins. So for this reason, a catheterized urine or a clean catch or midstream urine is advised, because semen is a protein on its own.
Yeah.
Some of you finish having said, I said that earlier. But vaginal washings or the secretion, the discharge, mucus, all these things, they are proteins. They can also make the protein to be detected, maybe as trace. or if possible, self. But depends on the person's judgment. But mostly stress. You write protein as stress. Now, if protein becomes 1 plus, what people causes could be urinary tract infection, or patient is having hypertension or fever, or a person passing through severe emotional stress, or person just finished maybe exercise can also cause that. So it can also lead to this. They call it mild proteinuria. Patient is said to be having mild proteinuria. Then if protein is moderate, like 2 plus, causes could include chronic glomerulonephritis, multiple myeloma, preeclampsia, pregnant women having hypertension, and then they might not be able to deliver through normal delivery. Okay, this is a very serious issue. Protein is very serious in pregnancy. Ladies that are pregnant and they check for proteins and protein is showing very serious. It only indicates that the patient tries to deliver, if it's not controlled by normal pregnancy, by normal delivery, patient might die. That is the situation. That is the meaning. Not might die. Mostly might die. You should put it that way. So preeclampsia is a serious condition for most pregnant women. And then the other, there's a pyelonephritis too. You're going to look at it, the kidney issue. So when you see 2 plus, they are not something you keep. You keep to yourself. That's why they said, especially abnormal results should be released as soon as possible. The results should be ready within 5 to 10 minutes. Doesn't take time. Then if the protein is showing 3 plus, that is marked proteinuria. Causes could include acute or chronic glomerulonephritis and nephrotic syndrome, and etc. Then glucose. If someone sees glucose, starts seeing glucose in urine, present in glucose to start in urine, that means the blood glucose would have been more than 180 milligram per DL or 10 millimole per liter. Okay, in the blood before this glucose will start being present in the urine, because in normal urine glucose is absent or in trace amount in normal urine. For somebody that is normal, glucose being present is negligible. So if you start seeing glucose 1 plus, 2 plus, 3 plus, is a serious matter, and the doctor has to be notified, or it will be stated in the result that the patient actually has this condition. And glucose is the only carbohydrate that causes pathology, that is of pathological significance in the body. Lactose is not that significant in urine, like talking about lactosuria. Sucrose is not significant in the urine, sucrosuria, or talk about maltose, fructose, from taking a lot of fruits, that is this thing you get from, the sugar you get from taking a lot of fruit, that is fructose, they're not too serious, even though they are much, they are high, and the distance, but that's why some urinalysis used to have ascorbic acid. There's what they call ascorbic acid parameter. So in case whereby patient is complaining, there are some things you also check out for. That one is another issue altogether. But our time goes on, we might touch that again. So because of my time, I'm rushing actually because of my time. And then ketone bodies. Yes, this now I want to talk more about this. This belongs to a group of 3 related substances. We have acetone, acetoacetic acid, and beta hydroxybutyric acid. These are 3 things that they call them ketone bodies. They can give rise to each other, depending on what to favor the other, And then once the body cannot use glucose, once the brain cannot use glucose, the next line of action is to start breaking down fats. Glucose is in the blood, but they can't use it because the receptors are not responding. The body cannot use it for energy. So they start using fat, breaking down fat in the body. And some of those fats will start being converted to acetone, acetoacetic acid, and beta hydroxybutyric acid. Now, all these things, when they are high in your body, in the bloodstream, they can cause the brain to damage, to shut down. If they are high, especially if the person is diabetic, or even if the person is not diabetic, this is a cause of coma. Somebody is walking on the way now, and the person fainted, or the person falls down and faints. That is as a result of as a result of what's it called? Ketone bodies. Coma, the person will be feeling dizzy. The eyes will turn the person. If you put this acetone, for example, in the lab, and you smell it with your nose, you smell it, you'll be feeling somehow. I don't know if you have attempted, I don't know if you visited the lab before. And you smell acetone. Some of these things, when you smell them, there's a way they make you feel somehow. How much more when they're in the blood? So they can shut down the brain, shut down your body system. So when this patient, when the brain is shutting down, the person is in coma, they call that diabetic keto, and it's due to the sugar, diabetes. They call it diabetic ketoacidosis because they are due to ketone bodies, and these are acetone, especially the beta hydroxybutyric acid and the acetoacetic acid. They call them because you can't in this bloodstream that they can give rise to the other. They exist like that in those three states. So they said the patient has. So it's a serious condition, and from that ketoacidosis, that coma, the patient dies. So it's very serious, and in some cases, potassium too will be low. So EUC, electrolyte test, might also be recommended too in this situation because sometimes potassium is depleted. So these things are very important. So urinalysis is paramount. So the other things I need to also talk about. Okay, then there's another one, bilirubin and urobilinogen. Okay, this is another issue, another marker. Breakdown of integrated being, and then for that, then if the bilirubin is not, this bilirubin now, unconjugated bilirubin now, as it comes to the liver, it has to be conjugated so that it can be excreted by the kidney. By the kidney, there's conjugated with glucuronic acid. So when you conjugate it, you call it conjugated bilirubin. From there, it passes to the intestine. Then it also gives you stew, the yellow color. Why you have yellow color or brown color in your stew? It's because of this bilirubin, urobilinogen issue, this thing, those breakdown. So that's urobilinogen converted to, even your yellow color, being broken down for urobilinogen to urobilin, that gives you, as I mentioned earlier, gives you part of the color, or in the stew, they call it stacobilin or stacobilinogen. Breaking down to stacobilin gives the stew is yellow color or brown color. So all this is from red color of blood broken down to yellow or brown color. Finally, all these things in the bit for the kidney so that the will to be excreted, because excess of it is not good for the body. So they have to be, excreted, degraded. But for it to be degraded, it has to be conjugated in the liver. This bilirubin. So when you see this bilirubin that is present, it will tell you that this patient has liver issue, has something to do with liver. Has person had liver issue, bilirubin 1+, 2+. There are some issues. So what the doctor will, if there are no other issues, what the doctor will recommend is liver function test. Please run a liver function test for this patient. Okay, even the protein. If protein is present, a doctor can also say, run a liver function test for this patient, or a kidney function test for this patient. So let me go ahead because of my time. Then the next one, we have leukocytes. What is actually measured here, being measured here, is leukocyte esterase. It's an enzyme. Okay, it's an enzyme. So the azurophilic or primary granules of granulocytes, mainly the neutrophils, demonstrate esterase activity. Here, the ester, what I mean by ester, how do I put it? The way you have salt, I don't know how to explain it, go further, but I'm trying to make you understand. Ester like can be something like a soap. When acid reacts to base, you get salt. But when something like, let's say, an alcohol or something, and then react with another group or another group like that, they can give you ester. I don't know how to come close to layman this thing, but that's what I mean, an ester. So an ester will be degraded by an esterase. The enzyme esterase, enzyme, something that causes a reaction to happen very fast. Is a substance, a protein. In some cases, protein. to give you alcohol. So if esterase act on ester to give you alcohol, the alcohol will combine with a diazonium salt that they impregnate in the strip to give you a purple azo dye, a purple dye, a purple color. So the intensity of the color will tell you the degree, whether it's 1+, 2+, 3+ of leukocyte to indicate. And when you see leukocyte plus, whether trace so 1+, 2+, it indicates urinary tract infection. Person has urinary tract infection, and the culture is usually recommended. Although the doctor might continue with, a guess drug. Oh, let me try this drug. This drug has been working for maybe 99% of patients. Try it while the result comes out. Depending on cope, if patient can cope, then you ask the patient to come back after 48 hours in most cases. Because after the culture results would have been ready, come back for the result and you give the patient the results. And then the final one I want to mention, because of my time here, is nitrites. Now, some bacteria like E. coli and some coliforms, E. coli, when I say E. coli, Escherichia coli is a bacterium that can cause to nitrite. Okay, when I say nitrate is a salt, can be a salt, usually a salt, to another salt, nitrite. So we convert NO3 salt to NO2 to reducing the oxidation state from +5 to +3. So when you see nitrite, is a pointer to E. coli or some other coliforms that are related to E. coli, like it might be Klebsiella. Okay, and then this can give you idea of what you're actually looking at for. So when you see this, and it takes, and this conversion really takes about 4 hours to be, to happen. Okay, it takes about 4 hours to happen with E. coli. So if not in enough cases whereby someone has infection that you see, or sure E. coli, that you will see nitrite positive. Person can have nitrite, nitrite might be negative, leukocyte might be positive or even trace or not at all. And then the culture is showing this patient has Escherichia coli. Yes, it's still correct, because for nitrite, especially, it takes 4 hours for this conversion to happen. So in the situation where the patient produced the urine at the time of doing culture, you might not see nitrite. The patient is complaining, and doctor says, go to the lab, and the lab gives bottle. Oh, you're complaining. Get your urine. Patient produces urine, and it's taking. So you won't say, oh, because there's no nitrate, therefore the result is invalid. No. So I think I should stop here. There are other things also look at. So this dipstick, I'm talking about the Urinalysis dipstick. We have Combi2, the one that checks for glucose and protein. The one nurses use, bedside, to check for glucose and protein. We have Combi9, or other Combi, but the common ones now are Combi9, or depending on the company. Okay, we can call it Combi is very common. And then Uriscreen 9 or Uriscreen 10, we have 11, we have 12. Now, the one we use in our lab now is 14. It has 14 parameters. You can also check for creatinine. You can also check for microalbumin. You can also check for calcium. And then also check for ascorbic acid, apart from other 10 parameters that are common that people know about. The pH, the specific gravity, the glucose, the leukocyte, the nitrite, the protein, the etc. Those 10 parameters. Somebody I mentioned all of them. The other people check, but my own now checks additional 4 parameters. And this is also necessary because someone might be having serious kidney disease and you might not know. So it's good to check them, get the latest dipstick and use it for your tests. And I believe what doing is what doing well. So thank you for the audience.
Thanks a lot for your time.
I don't even know your name. I'm Robertson. Okay, Mr. Robertson Klenga.
Yeah.
Okay.
Thanks a lot for
Thank
taking
you.
the time to do this. I'm sure everyone that's listening to it is going to have learned a lot more about urinalysis and why it's an important test to do, what some of the different parameters that are actually tested are, and what each one can give you an idea of when it comes to your health. So it's a very important test. It's one we need to do more often. It's one that laboratories should spend more time on. Thanks a lot. And hopefully we'll have you again very soon to enlighten us a little bit more about this.
Yeah, my pleasure.
Yeah.
Okay, yeah, take care. Bye.
Nice.